So to keep on time, we're going to start our panel. We're very, very excited. Ipsita Smolinski is going to be our moderator. She is the founder and managing director of Capitol Street. She's also on the faculty of Georgetown and Johns Hopkins, so that's great, and the senior strategic advisor for McAllister and Quinn. And with that, I'll turn it over so you can intensify all of your insights and be exciting. Thank you.
All right. Well, thank you for having me back this year. This might be my third year. There was a couple of virtual years in there, so maybe it was the fourth year, but always loved being in sunny Southern California and had to eat my lunch outside given the vitamin D, so the weather gods have cooperated. Our panel today is on evolving business models. And we've got an amazing panel. We've had a few pre-calls to really hash out what we want to convey. And just like the other panels, we really want to make it interactive. So please, we welcome your questions and your insights. We do all have some slides to share. And what we'll do is we'll start with those. I'll have each of my panelists run through their extremely stellar bios instead of me reading off of a piece of paper. So please introduce yourselves before you go. And I was going to just kick off with some healthcare trends in the policy world, in the business world that we see from our spot in DC. Our firm, Capitol Street, is a healthcare policy consultancy, so we're really not doing much advocacy or government affairs work. It's more analysis, looking at data, evidence. You know, these bills are likely to move. These regulations are this one paragraph of this 1,700-page Medicare inpatient hospital regulation is impactful. The rest of it really doesn't matter. So we're really trying to cut through the noise and the headlines to really provide the impacts of key regulations, legislations, court cases. As you know, the courts are often weighing in on healthcare. So that is Capitol Street in a nutshell. And the last thing I'll say about our firm and our perspective is really that we are very in tune with what the capital markets are thinking about at any given time. You know, are drugs in favor? Are hospitals out of favor? And again, these are the publicly traded companies. We work with institutional investors, with private investors, PE investors. In fact, Chris is going to tell us what PE actually does and how it pertains to healthcare, since that's really been a hot topic. And we have other clients, hospital systems, trade associations, et cetera. But that's my lens, and wanted to just run through a few quick trends and themes, and then I'll pass it over to my next panelist speaker. Here we go. So 2024, here we are. We heard in great detail from Dean about the election, which is really a big overhang for the year. You'd be surprised, the election moves the markets every single presidential year, whether it's Medicare for all or drug pricing. Typically, there's quite a bit of volatility in the markets leading up to an election and after the election. This year, it feels like healthcare isn't featuring quite as big, but just some themes here that you'll see on the slide. Healthcare workforce, of course, we know we had a loss of labor even pre-COVID, and that really exacerbated the Great Resignation. Telehealth, still very topical. You know, that genie has come out of the bottle. And I think Congress will extend a lot of those PHE-era flexibilities. So that'll be up for debate at the end of the year. Drug price negotiation, of course, Mina talked about that. 10 drugs. I mean, this is kind of a watershed moment, if you ask me. Medicare can finally negotiate drugs, you know, since Part D started in, 2004 or 5. So that's kind of exciting. And by the way, I'm not a Republican or a Democrat. I think both parties suck. So I am a capitalist, though, and just wanted to provide that background, my disclosures, if you will. So Congress, many members of Congress, the agencies are pretty anti-consolidation. You know, the agencies seem to have had their target on the back of tech companies. Healthcare is kind of a close second, quite honestly, with a number of big mergers and deals being challenged this year, last year. A few other things here, site neutral. We were talking about that a little bit in an earlier panel, this idea that hospitals are buying up less costly sites of care, whether they're surgery centers, physician offices, and then billing at that higher rate and then profiting off of that arbitrage, which is something that quite honestly has happened for years. Congress now seems to be willing to do something about that, maybe not this year, but certainly in the out years. On the insurance side, at the top of this chart, Medicare Advantage, over 50%, 50% of seniors are in a plan. They like it, they vote. So as you can imagine, members of Congress hear from them on the program. And the program's in a little bit of a, I guess, pivot point, given that there is some perceived, I guess, upcoding their HCCs to really garner additional payments from the government, which is certainly happening. So we could see some payment reductions, refinements to MA in the out years. Also on the insurance side, we've had a big exodus of Medicaid folks from the state rolls because of redeterminations, which is something that states really have not been able to do, which is to re-verify that everybody in their state that has Medicaid is indeed still eligible. Many of them have, become employed, et cetera, and now have access to employer-sponsored insurance and no longer belong in Medicaid. So the Medicaid rolls have shrunk, and then the marketplace has grown. Again, this is the exchange market that was created through the Affordable Care Act and has seen some really healthy growth as far as enrollment just in the last few months. Mental health, behavioral health, you heard about that on the state panel. Of course, a big focus in Washington. And price transparency is something in drugs and really across the board, hospitals, medical technologies. It's almost like motherhood and apple pie. It really doesn't matter what state you're from or what political party you're in. You kind of want to know what you're going to be paying for an MRI and whether it's more expensive at your community hospital or less expensive and more expensive at the hospital down the street. This idea that Americans really should have some access to price transparency. GLP-1s are, of course, the new weight loss drugs that, it's even filling up my Instagram. Obviously, very costly medications. Compounding pharmacies are making them to kind of skirt the rules, and the Medicare program currently is not able to cover obesity drugs in the over 65 population. So that's something that is being lobbied heavily in Washington right now to change that restriction that, again, the Medicare program cannot cover obesity drugs, but we're seeing cardiovascular benefit, we're seeing kidney, renal benefit from the GLP-1s, so we think it's a matter of time before Medicare does cover those drugs, but it might take a little while. And then PBMs, these are the middlemen, these are the Optums of the world. They're under a lot of scrutiny in Washington right now as having a very non-transparent business model, and we'll probably see some more restrictions on the way they operate, if not this year, then next year. It's a very bipartisan, bicameral area of interest. And now that the Inflation Reduction Act has passed and there's some guardrails for drug makers, the popular thinking among the healthcare staffers and committees is, okay, PBMs are next, and maybe even Medicare Advantage plans in that same priority list of industries to regulate. So with that, I will, instead of going through my long deck here, pass it on to Steve Pearson, who's going to discuss drug pricing, drug discovery. I'll give it to you.
I kind of wish, I felt so clever coming up with this idea of including the Oscars. Dean Rosen, I tell you. I'm Steve Pearson. I grew up in California. I went to college and medical school here. So it's always a delight to be back, and I really am pleased to be here. I came years ago, but ICER, which I founded out on the East Coast, Institute for Clinical and Economic Review, is what's generally known as a health technology assessment group. That sounds like a very boring endeavor, but I'm going to try to tell you briefly in my presentation why it's not boring and in a sense, it's tied a bit to this gentleman. I did think it was an appropriate theme, partly because every once in a while, or maybe more often than we think, science creates wonderful new opportunities that also represent tremendous challenges for society. And obviously, Oppenheimer was aware of the challenges that the atom bomb would represent for mankind, and Cillian Murphy was the perfect person to look distraught while also being gorgeous, right? So what are healthcare's atom bombs right now? I think there are really two of them. At the quantum level, if I can hang tenuously on to this analogy of atomic physics, at the quantum level, we have truly transformative gene therapies. Now, the prices have been, scaling from 1 to 3.5 million. That's at the early era, and they could go north from there. We're also starting to see these gene therapies, which you might think is a kind of a cure for a very, very rare condition, now being prepared, delivered to conditions that represent larger populations. Now, sickle cell disease isn't a huge population, but when you start to think of $1 to $3 million times 200,000 Americans, you get into the many, many billions of dollars. And access to gene therapy is already under stress. So we've got this tremendously transformative treatment for many patients, and it's already under pressure. Some small employers are saying, I cannot afford this. I can't take the risk that someone in my small company is going to pop up and need one of these $3 million treatments. I'm going to ask my insurance company to exclude them from coverage entirely, all gene therapies. So there are arguments about how many employers are now excluding these from coverage, but it's a growing tension. And partly that is being driven by the concern that there are 800 gene therapies now in clinical development. All right, so not all of those are going to come into clinical practice, but there's going to be a wave, and it's going to create even more concern about how we manage this tremendous scientific achievement. So that's at the quantum level. At the cosmic level, we have GLP-1s. So a very different kind of wonderful transformative therapy and a very different kind of social challenge. So here we've got 40% of Americans eligible for these treatments. In all of 2020, there were 16 million prescriptions filled, and that was just for patients with diabetes, because that was the indication at the time. In just 3 quarters of 2023, 51 million prescriptions were filled. And around 50% of employers and other plan sponsors are now covering these treatments for obesity. But some have covered it and then said, yikes, I thought I knew, but I didn't really know how this was going to hit the bottom line, and now I'm going to have to take it away because they just can't afford it. So this is nothing new in our healthcare system, but we've got it both at the quantum level, almost the N of 1 level, if you will, and we've got it at the very large population level. We have tremendous transformative treatments benefiting millions of patients, and we are having a really hard time figuring out how to pay for it. So let's talk about business models. Oh, by the way, there is that little tiny thing at the bottom, which is that the United States is the only developed country that does not negotiate launch prices. The Medicare program will negotiate 10 years in if there's no generic competition. We are the only developed country without a governmental approach to negotiating, managing launch prices. So we have to figure out what to do in that context. So this challenge of balancing innovation, access, and affordability is a scientific problem, right? It's a financial problem, or opportunity problem, and it's also an ethical challenge, because we really have to figure out how to balance innovation, access, and affordability. And at each ICER public meeting that we have on one of these therapies, I have a slide where it says, our goal today is to talk about and to focus on the needs and the opportunities, what we can do to improve the lives of individuals and their families with this condition. But around them, around all of us are other families with their needs, healthcare needs, other needs that we have to pay for as a society, and we have to figure out a way to keep our eye on the middle, but see the community around them. around all of us. So that is the challenge that we have to figure out what we're going to do. So I'm going to give just a tiny bit of a brief on what ICER does as one contribution to helping manage that challenge, and then we'll turn to the business models that the pharmaceutical industry and the payer industry are starting to take to manage this. So there's an old question. Why don't we just price things fairly by figuring out what value they represent? And what does that look like? Now, this idea seems intuitive to a lot of people, but it certainly scares the pharmaceutical industry quite a lot. And by extension, it has worried some patient advocates and others around access and around fairness. So even some Democrats are concerned about this. But what does it actually mean to price to value? Let me give you a tiny graphic display. I'll make sure I'm sensitive to time. The middle dot here, let's say that represents our best current care for patients with heart failure. And versus nothing, it represents a certain overall health benefit. It's better than nothing, and it represents a certain overall cost. But that's where we're starting from, that dot in the middle. Now we live in an innovative ecosystem, so we have a first new drug, and we can figure out that it helps people live longer, it might help them function better, have a better quality of life, and its overall cost, even if it keeps people out of the hospital sometime, its overall cost is more expensive. So we might ask a question about whether that drug is priced fairly. But what if we also have a second new drug that, as you can see, is even a little bit better on its health benefit than the first new drug, but it is much more expensive? Cost effectiveness as an approach to value-based pricing says we have choices to make here. We have to figure out what we are willing or able to pay for better health. That's not an easy question to ask an individual patient, an individual doctor, a hospital, a society. But it is the question that this presents, if you will. And cost effectiveness usually comes up with some threshold or range, meaning that any price that's within that blue zone is in alignment fairly enough with its added benefit to represent a good value for our society. And there are lots of arguments around how you figure out where that threshold is. But you do, in the right way, try to figure out how much can we spend on something good for one patient without doing more harm to other people by driving up the costs for everybody. We try to use data to figure that out. But the value-based price of the first drug, you would say it's fairly priced today. The value-based price for the second drug is the price at which it falls within that zone or lower. And that's as simple and as complex as value-based pricing is. But it's never the only part of the equation. We also have to realize that value, as determined by cost effectiveness, it has to be tempered by the uncertainty around how long we know the effect of a drug will be or other treatment, maybe unknown safety risks in the longer term. We do have to think about our social values. Do we feel we will pay more or should pay more for conditions that are more serious than others? Maybe there are spillover effects of new treatments, new innovation for caregivers, for employers and society. We have to figure out whether any treatment like a gene therapy that might prevent downstream costs, should all of those costs get wrapped up and given to the inventor of the gene therapy as a fair price? Or do we share that cost offset if we can do so? And we also have to think about what's long-term value versus what we can afford in the short term. So all of these I'm not going to go into great detail, but just to note that this means that this is never, what a fair price is never an easy equation, but it can be done transparently and rigorously and with input from all stakeholders in a way that our country is uniquely not good at. So what are the emerging business models? First, on gene therapies, okay, for payers first, to a certain extent, they're still, and employers are still relying a fair amount on what's called stop-loss insurance. That you buy secondary insurance, which means that if I have an unusual kind of expense that's way higher for a single patient, I only have to pay up to a certain amount. I'm the primary insurer, and then I've got secondary insurance to back me up. That's not going to be the perfect solution, though, for a variety of reasons, especially when we have gene therapies for conditions like sickle cell where you can see it coming. You know which people are going to need that treatment, and insurance never works well when they know exactly who's going to be expensive. Payers are also trying to figure out how to create brand new models in which you can carve out the costs of gene therapy and try to pool a lot of different payers together. There's one called Embark that's offered by Cigna, but all of the major insurers now have these carve-out subscription models. The pharmaceutical industry, those who are developing gene therapies, they're quite fond of trying to say, look, the only problem here is not that it's 3.5 million, it's that you have to pay that all at once. So let's figure out a way that we can pay over time, and maybe if the therapy wears off, we'll pay you some back. So everybody's trying to come up with these new payment models as a way to help, if you will, kind of recognize the value of great one-time treatments, but not have the shock and awe of the budget impact hitting all at once. On the GLP obesity drugs, nobody's got a good idea for this one yet. Nobody does. This is, for payers, the biggest affordability challenge in their history. There is nothing. Hepatitis C, no. HIV in its day, no. This represents the biggest affordability challenge for the private commercial market that I think has happened at least in decades. So what are people doing? Well, some of them are saying, I'm not going to cover it, and especially employers. This is being left up largely to employers who will either say, I'm not covering it. Some health plans are trying to narrow the eligibility in a variety of different ways. Some are more or less based on evidence. And payers are now creating new branded carve-out programs where they say, you, employer, will take care of all your patients who are obese, and we'll just take care of them, and we'll figure out which really need the meds and which can do lifestyle changes instead, and overall, we'll just do a good comprehensive care, and it'll be less expensive for you. Completely untested, really, so far in the marketplace. For pharma, this represents their biggest market opportunity in history. Every single company's stock price rises and falls today with whether they do or don't have a GLP-1 obesity drug in their pipeline. It's almost universal. And they're all trying to figure out what's the 2.0 version. You know, the first generation, California, I think, was way in the cutting edge on this, Hollywood probably, right? I can lose weight, but I'm losing muscle mass. So the version 2.0 is weight loss with retaining your muscles. So there's all kinds of a race for the next version of Wegovy. And pharma's also trying to figure out if they can own the entire process. Do we buy manufacturers of our drug and the whole distribution chain? Do we just kind of reach out there and create a new direct way for patients to get this? So in conclusion, again, I just want to pull back and say that the atomic bomb challenges that healthcare faces are, again, at the micro level and the macro level at the same time, and that this is an eternal challenge for us. It's never not been there, and it never will go away entirely, but it's in a particular point of stress right now. So the value assessment approaches that ICER has used and are used a lot overseas has been a foundational tool for societies to help judge what a fair price is, what we can afford, what we should afford, how much incentives we're willing to give back to manufacturers. But it cannot solve all problems by itself. And so that in healthcare, as in physics, at both the small and the large kind of population level, the normal rules for how competition is going to lead to fair prices, or a private healthcare kind of insurance world will figure out how to deal with access and equity, it's not going to happen by itself. And there are going to be a lot of efforts at innovative business models to try to get this right, and they can't do it by themselves. Every time we convene a group to talk about gene therapies, the private companies say, we need Washington to do this. Otherwise, it's not going to work. And what does it mean to not work? I think it's really critical to remember that what might work in the US context are solutions that will increase health inequity. Gene therapies are a great example. We're not even talking about US versus Africa, where they will never see a gene therapy for sickle cell. And we're arguing about how to pay for it here. But even in the US, some of these business solutions are going to lead to kind of diversification within the business models that will lead to winners and losers. And I think we all have to work to keep each other accountable to view that the best outcome of figuring out how to take care of ourselves at the micro and the macro level should have equity at its very heart. So thank you very much, and I really look forward to the other presentations.
Good afternoon. Let's try that again. Good afternoon. We talked about this earlier. We were going to make this the most fun panel of the day, right? So I think I have to do like interpretive dance or some light shows, etc. It is a pleasure to be here with you guys. Rishi Manchanda with HealthBegins. I want to speak about the promise, the peril, and the opportunity of this moment right now, especially when it pertains to changing business models related to health equity and the social drivers of health equity. Do you all remember Mina Seshemeni's one beautiful kind of presentation, incredible presentation this morning? And she shared a story about a patient from her days providing care, a patient who was coming to the ER about 17 times in about 3 months, and how they finally sent a community health worker into the home, and they found out it was because of electricity outages that led to the asthma, right? Remember that story? So my presentation is going to double click on that story and go a little deeper. And particularly because there are social needs that story kind of exemplifies of that patient that a lot of folks in Medicaid and a lot of folks in Medicare and commercial sectors are trying to address right now. And of course it has equity implications if you think about that person that Mina spoke about, and we look at the patterns of people who experience similar problems, they're clearly kind of patterns of inequity that she was speaking to as well. So may I kind of bring you back to that story that she shared this morning and allow you to kind of go deeper with me now into this specific question of what we are talking about for the next 9-10 minutes. I run an organization. I'm a primary care physician, have worked in a variety of settings, FQHCs, at the VA, building clinics for homeless veterans, and in the Central Valley of California, building clinics for farm workers. I started an organization called HealthBegins many years ago, and this is who we are. You can see it up there. A national organization that helps Medicaid managed care plans, health systems, and community partners to be able to meet all the growing healthcare equity and social needs requirements in the Medicaid space, but do so with a deep understanding of, frankly, just public health and how to get stuff done in order to achieve more than compliance, real impact. And so there's been a lot of work across the years. This is from 2022. We've had the privilege of working across the country. The map looks bigger in 23, and we're privileged to do a lot of work here in California and outside as well. The presentations this morning in particular really exemplified a lot of the things that I think are worth celebrating when you consider equity and social drivers of equity. We know, as you heard this morning, there's a lot in Medicaid and in Medicare when it comes to integration of social needs or social care integration, as well as equity. You can see it in Medicaid 1115 demonstration programs, including here in California with CalAIM. You can see it in Medicare in a variety of traditional and Medicare Advantage kind of spaces as well. New models, the ACR REACH model, et cetera as well. There's a lot that's been happening, especially in the past 3 to 5 years in that space. That's also meant it's not just what Medicaid and Medicare are doing, you're also seeing this translate into the quality space. So quality measures now are emerging to be able to help track how well and how, if at all, we're actually screening for social needs like food insecurity, housing, et cetera. And also how that is baking itself into the quality reporting infrastructure that exists in healthcare. So we're seeing now integration in that context. And we're also seeing, let me see if I can, there we go. We're also seeing this emerge in the accreditation bodies. The Joint Commission, for example, now has new requirements for hospitals to screen for social needs and provide resources to those who screen positive. There is a specific healthcare equity certification program that the Joint Commission has put out, and already we've seen 8 hospitals achieve in the first cohort that program. We're going to see this scale up across the country as the Joint Commission promulgates this. The NCQA as well, which does a lot of accreditation, especially for the health plan space, has an updated accreditation program as well called Health Equity Accreditation, or HEA+, 2 different versions that plans can benefit from too. The point here, if you're getting confused with all the acronyms, is that equity and social needs are now integrating themselves into the acronyms of healthcare, right? This is a huge advance. If we drill into the Medicaid space, especially looking at, of course, states where Medicaid happens, more than half of managed care organization states across the country, according to Kaiser Family Foundation, we have KFF in the house here. Yep, Liz. So Thank you for the wonderful work of KFF. We know, according to their research, that more than half of managed care states reported requiring managed care organizations to screen for social needs, provide referrals to social services, and partner with community-based organizations. And this is data from 2022. The number has increased since 2021, and we expect the same trends to be happening in 23 and, of course, this year and beyond. It's notable that while fewer states have required, this other thing at the bottom, fewer states, but some states, although fewer, have requirements as well for managed care organizations to invest back into the communities some portion of their proceeds. And we'll likely see that requirement increase as more and more states adopt this. When it comes to equity, healthcare equity specifically, we're also seeing similar trends, an increase in the number of states where managed care is the predominant kind of delivery. For Medicaid, we're seeing requirements to make sure that at least a quarter of states have at least one financial incentive tied to a health equity-related performance goal. Overall, over one-third of these states have at least one requirement to address health equity, including some financial incentives attached to it. If you think about the market size, the dollar figures attached with Medicaid dollars, and you think about what this means now, healthcare equity and social needs now are part of Medicaid more than ever, and partly because they're reacting to the growing body of evidence. Just one example, in the New England Journal of Medicine Catalyst journal, preliminary evidence showing that hospitals in Massachusetts with more robust social determinants of health programs, meaning those that address social needs of patients, had reported higher patient experience scores and had, this is the atom bomb for me, lower mortality rates for key cardiovascular conditions. Just think about that for a second. Hospitals that had more social determinants of health programs associated with lower mortality rates for these conditions. There's still more research to be done here, but if this association has some causation associated with it, then we're now talking about a growing body of evidence showing that addressing those issues that Mina spoke about this morning for that one patient actually shows impact, and this is why we're seeing this now in the field. So a lot to celebrate. For those of us, like myself, a clinician, any other clinicians in the house? Those who've practiced healthcare in any kind of capacity, right? Yeah. Anyone been a patient? Don't raise your hands for HIPAA purposes. You know that social context matters. We know that the healthcare system has not been set up to be able to address the kind of unmet needs of individuals, whether behavioral or social, and yet when we are able to do that, we're able to achieve that higher standard of care. Now, finally, the healthcare field, as you can see, is starting to catch up with that common sense kind of understanding on the ground. The business models have started to evolve, the policy environment at least has. But there is risk. The risks are many. Here are a few of my choice selection. As Stephen, you mentioned as well, and I think as others have mentioned throughout the day, including the presentations this morning, when we fail to center equity in healthcare policy and in the business models, it is not surprising. In fact, it is entirely predictable that what will result is perpetuation of inequity. There was a review published last year, again in the New England Journal of Medicine, reviewing the past 10 years of value-based payment programs out of CMS, and what they found was that those models, while having advanced the field towards value far better than volume-based payments, did not have equity baked into the design of those, and therefore actually ended up perpetuating structural inequities, including inequities, racial inequities, right, in terms of outcomes. The key kind of point here from all the evidence is clear and common sense. If equity is not baked into the policy design and implementation of an initiative, inequity will persist and result. There is no kind of happy middle ground, like let's just kind of roll the dice and hope that inequities get better. It has to be baked into the design. Does that resonate? Anybody here? Does that resonate? Yeah? Good. The other thing is this, I think what we're seeing is that there's an understandable fixation. There's understandable desire to get ROI out of these efforts to be able to close healthcare inequities and social needs. I would call it a fixation. But similar to, I think, some of the short-term kind of thinking, Steve, that you spoke about in your presentation, sometimes the focus on a narrow set of returns, a narrow set of outcomes, for example, changes in ED visits or hospital admission rates, sacrifices the ability to capture value that might exist of interventions, even in a short-term horizon, right? So for example, workforce productivity, workforce satisfaction, patient satisfaction. There's a variety of healthcare-related outcomes that often aren't tracked to track the true returns of interventions like the ones that Mina spoke about this morning. It also is true that this fixation on the short-term 12-month kind of return may not allow us to actually capture the real benefit that takes sometimes longer than 12 months, for example, to see the benefits at a population level for these interventions. And so how do we actually navigate that? Current business models also limit some of the investments. We're seeing this right now in a moment of contraction in a lot of healthcare systems and in plans right now, where the commitment to equity made by many organizations in the wake of George Floyd's murder 3 years ago are now being, that commitment is now withering because of budget contractions, et cetera. And so it really begs the question of, like, what was that commitment about? But it says not so much about a moral kind of leadership question, it's also a financial kind of question. What does it mean, actually, if equity is not kind of factored into the true kind of machinery of the enterprise? What does it mean about the business models when that is at risk, when equity is sacrificed at the altar of expediency? And the last point is this, is that many healthcare payers and vendors lack accountability to key stakeholders, most notably the very stakeholders that are most impacted by these inequities. Right? There are very few, with the exception of, say, FQHCs, there are very few organizational structures and governance bodies right now that exist in healthcare where the stakeholders, not the shareholders of these efforts, especially those people who are impacted by inequities, have any say, period, in this kind of space. And that's a fundamental challenge. That's not just a new one. It's been there for a long time, but it makes it really difficult for a lot of, as we're seeing it day to day with the health equity leaders that we work with across the country, especially in Medicaid. It makes it really difficult for their work to be able to say, well, there is real value for a program, for example, to reduce maternal health inequities right now. There is value, as you can hear from this mom or this family here, of an intervention to provide doulas for the service, and yet their voices are not part of the governance-making bodies or the shareholder kind of conversations. And so with that delta, the people who are not in the room are the ones, of course, whose values and opinions and sense of value, economic value, is just not included. Let me go deeper really quickly into some of these risks as well that I think are really relevant. There's a lot of bridges to nowhere. Healthcare systems, we're screening people for social needs now have very limited resources to connect them to in the community. Where do you go if there's not enough resources in the social sector? Not because of lack of will or desire or mission for social sector organizations, but frankly, lack of capacity. The wrong pocket problem is there as well. What happens when the benefits of a healthcare investment accumulate to the benefit of the healthcare system, but not necessarily to others who benefit from that investment too? And then extractive practices also undermine equity. Profiteering, debt collection, and other extractive practices not only contribute to poverty and inequality, according to a lot of the kind of research that's been around for a little bit of time and picking up pace right now. I'm looking forward to seeing what Chris says about his research. But they also depend upon them. Matthew Desmond wrote a powerful book, Pulitzer Prize-winning author last year, called Poverty in America, where the central kind of tenet of the book is poverty exists in America not because of a failure of policy, but because that's exactly the output that we seek right now, because there are organizations and institutions that benefit from it. Same is true for extractive practices in healthcare that sometimes actually perpetuate inequity and actually depend upon that inequity in order to continue to kind of operate in this way. If this is making you uncomfortable, just imagine what it's like to be the person being sued by your hospital. So if you're low income and otherwise would have qualified for benefits. So what does this mean? Am I bringing you down? Business model implications. I think there's actually real potential here, and there's real opportunity, especially if we look at the vanguards that we have the privilege of working with. There's an opportunity to assess the value on investment, which includes both financial as well as non-financial economic benefits to institutions for investing in social needs work. There's real value propositions that are being left on the table. We just have to start moving from calculating ROI to calculating the value on investment. We need to help healthcare leaders who are trying to do this work, whether it's equity work or any other kind of major priority around quality and safety, manage portfolios of interventions rather than a patchwork of programs, and especially the patchwork of vendors who have a lot of point solutions that are going to solve everything. When you're the healthcare leader and working at a plan or health system, it's very difficult to manage the complexity of all the different vendors and all the different programs that you have, especially when you're just trying to meet compliance standards. How do you move to becoming a manager of a portfolio? And to do so, how can we make sure we provide healthcare with an investment menu? There's evidence now, enough evidence of the impact of a lot of interventions to address social needs. We haven't yet delivered and packaged those interventions into a menu of investments that allow impact investors, healthcare investors to now see how they can get the most bang for their buck, most return and value and impact for investments to be able to treat outcomes, for example, for the patient that Mina talked about this morning. And last but not least, we need new investment models as well to address some of the fundamental flaws in the current market, including the lack of incentives for preventative care. This is my last slide, and it's it's a social proof. It's evidence of what's starting to happen. At the federal level, ARPA-H, if you guys are familiar with ARPA-H, it's a new federal initiative that has really started to drive a lot of innovation around a lot of important healthcare outcomes. They have a new program called the HEROES program. The letters of interest are due next week. And what they're proposing to do, this is the federal government with ARPA funding, is to say, can we start to pull together capital from buyers of outcomes? So for example, in Orange County, what would it be like for the health plans, health systems, and others to pool resources to buy outcomes like improvements in maternal health or in substance use disorder or a number of other outcomes that ARPA has identified here. This is a way of pooling kind of capital to be able to bring outcome buyers together to buy the outcomes. I saw in Steve your slide earlier about gene therapy. One of the new models that has been considered is outcomes-based contracts. This is a similar kind of idea here that can work, especially to avoid some of the challenges that we see when one institution, one plan, one healthcare system may not see the full value proposition of investing all their own dollars into an initiative that's going to yield benefit for a whole community. There are models that allow us to pool outcomes and contracts together to make that happen. So if you're interested, submit an LOI for this, because there is great opportunity, even though there's great promise and some peril as well. Thanks.
All right. Thank you all for your attention. I know we're still recovering from lunch. So my name's Chris. I'm an internal medicine resident doctor at Brigham and Women's, and I also do research at Harvard Medical School. And I'm really excited to talk to you all about private equity in healthcare, trends, effects on patients, and opportunities for policy. So I want to first extend heartfelt gratitude to the California Healthcare Foundation and UCI, the CHCF, for funding our three-part policy series coming out later this year, as well as to my collaborator, Dr. Zuri-san, who is a primary care doctor and economist at HMS. So taking a step back, I want to first start by talking about how a private equity firm operates and what happens when a PE firm makes an investment in a healthcare organization. So private equity firms receive investments from limited partners, and this may include pension funds, university endowments, high net worth individuals, and PE firms take that money and invest that money in return for management fees and typically a proportion of the received profits. When a PE firm makes an acquisition, on average, 70% of that acquisition price is gathered from debt. And importantly, the acquired organization is typically responsible for repaying that debt. For the remaining 30%, typically the limited partners will make up, on average, 28%, and the PE firm itself will contribute, on average, 2% of the acquisition price. And as you can see here, this structure allows a PE firm to achieve proportionally higher returns on its relatively small initial investment, and also shifts the financial risk to the acquired healthcare entity, who is now responsible for repaying the debt from the leveraged buyout. The other factor that can distinguish private equity from other for-profit ownership models in healthcare is a focus on achieving relatively quick returns, typically within 3 to 7 years. A PE firm will seek to buy and resell an asset. And so as you can see here, private equity ownership of healthcare organizations is growing rapidly, both in California and nationally. And it's estimated that in 2023, at least 4% of hospitals, 11% of nursing homes, and 2% of all outpatient physician practices are now PE owned, although this is almost certainly an underestimate, as such deals are not required to be publicly reported. So average returns from private equity investments over the past 30 years have averaged 13% per year, compared to the stock market average, which has been around 8%. And so to achieve such high returns, private equity organizations typically draw on several strategies, and I'll just highlight a few here. First is a focus on increasing consolidation, often through roll-up practices or roll-up purchases. Typically, a private equity firm will seek to acquire a so-called platform practice in a geographic area, and then acquire subsequently similar practices that are either nearby geographically and or in the same specialty. These roll-up purchases allow a PE firm to achieve higher negotiated prices and higher market power, and these prices are subsequently passed along to patients as well as to health insurance plans. A second business strategy, of course, is to reduce the costs of operating a business. And in healthcare, a large proportion of costs, of course, come from staff. And so what we've seen from our research is that after acquiring a healthcare organization, either the number of staff or the composition of staff will change, often to reduce costs and also to expand volume. And then third, PE is somewhat unique among for-profit ownership businesses in healthcare for the high use of leverage or debt to finance purchases, as well as a very swift use of reducing staff after acquiring a practice. And emerging research suggests that this may worsen long-term outcomes. So I want to review a study here and kind of go through a couple research papers that I think can be very helpful for policymakers as they consider how to address thoughtfully the impact of private equity in healthcare. So this study was published in JAMA Health Forum and looked at 600 outpatient private equity acquired practices and compared these practices to matched controls. And they found that after acquisition, PE acquired outpatient practices had 20% higher charges, and which resulted in 11% higher prices. Also accompanying this was an increase in volume by about 26%, as well as an increase in billing intensity by 10%. And it's important to note that these changes were not explained by changes in patient composition. A second study by our group, published in Health Affairs, found that after acquisition, outpatient practices increased hiring of nurse practitioners and physician assistants with no overall change in hiring of physicians. A separate New York Times investigation found that such hiring practices may be used to increase the throughput of highly reimbursed procedures, such as skin biopsies in outpatient dermatology practices, with unclear clinical benefit. This landmark study of PE-acquired nursing homes found that acquisition was associated with 11% higher mortality in nursing home residents. The authors postulated that this was because PE acquisition was associated with a 3% reduction in certified nursing hours. And these are nurses who are responsible for critical tasks such as mobilizing patients, making sure they get out of bed, cleaning patients. And this was associated with higher pain scores, reduced mobility, and in some cases, higher use of antipsychotics. And so I think it's also important to note here, you see that nursing hours for registered nurses actually increased after private equity acquisition. And so when we think about what effects PE acquisition has on patients and healthcare entities, it's important to be very honest and show the breadth of data. And in here, the authors postulate that RN hours are actually quite tightly regulated by CMS, who requires a registered nurse to be on staff physically for 40 hours a week. So it's very difficult for a nursing home to reduce RN staffing hours. So this may be one reason why this didn't change and actually increased after acquisition. Finally, in this study that was published in JAMA 1 month ago, of 51 PE-acquired hospitals and 260 matched controls, PE acquisition was associated with a 25% increase in adverse hospital events, which was driven by a 27% increase in falls, a 38% increase in central line infections, and a doubling of surgical site infections. Again, just being very honest about the data, we did find that in this study, mortality actually decreased by 3% in PE-acquired hospitals. However, this was likely explained because after acquisition, patients at PE-acquired hospitals were younger and more likely to be transferred to a higher acuity hospital when they became ill. And so I think that finding of lower mortality is most likely to be artifactual, although of course more research is needed. On the other hand, these in-hospital adverse events are more likely to be reflective truly of the care that you receive at the hospital, because no matter your background as a patient, getting an infection after surgery, having a fall, these are things that are reflective of the care and quality of the hospital itself, more likely. And while this study didn't look at staffing changes per se, other research has found that such adverse events are very tightly correlated with appropriate levels of staffing. That, yes, as of 2023.
Are there any household names that we would know as far as, just out of curiosity?
Yeah, so I think HCA is the big one, but that has been sort of, they've bought and sold. Yeah, that used to be. Yeah, I would, yeah. That's a good question. The final thing that I think certainly there's not as much research in this area and is a topic of ongoing work is the question of whether leveraged buyouts and another business strategy called sale-leasebacks has adverse effects on patients. And so as we discussed earlier, PE firms typically purchase nursing homes using large amounts of debt, and the nursing home is responsible for repaying that debt after purchase. One strategy called a sale-leaseback involves the PE firm selling the real estate from a nursing home, which can then be distributed to shareholders and investors, as profit. The nursing home is then responsible for repaying rent on the land that it used to own. Sometimes the rent can be at above market rates. And there have been some concerns in reporting that quality and staffing may fall because there is, of course, increased financial pressure now. In long term, this may be associated with a higher risk of bankruptcy. However, there is no research specifically in healthcare on this. Outside of healthcare, such leveraged buyouts are associated with a tenfold higher risk of bankruptcy. So as an example, in 2007, the Carlyle Group purchased the nursing home chain HCR Manor Care for $6.3 billion, 3/4 of which was debt financed. And in 2011, the Carlyle Group sold HCR for $6.1 billion, the real estate for $6.1 billion. Manor Care struggled to make payments after that, and in the ensuing years, serious health code violations increased by 26% annually. And these include phenomena such as medication errors or untreated pressure sores. And then in 2018, HCR declared bankruptcy. So I think it's very important to take a moment and pause because while these anecdotes are very striking, there is not as much systematic research on these particular financial practices. And of course, the PE industry is very diverse, very heterogeneous, and while there's a lot of research on this area, most often we look at averages. And so some PE firms are going to perform better than others. In addition, it's important to note that many private equity acquired hospitals have remained open and have remained very profitable for the PE firm. And so it's really unclear whether or not these business practices increase the likelihood of closure. And finally, many physician groups and healthcare entities seek out private equity investment. And commonly offered reasons for this include the need for short-term infusions of capital, the managerial expertise PE firms provide, the technology that PE firms provide. And so certainly it's a very complex issue, and we need to do more to understand what is exactly going on. With that in mind, given the rapid pace of private equity investment in healthcare, it is worthwhile for policymakers to consider different opportunities for intervention. So I now want to review a couple options that we published last year in JAMA in a policy proposal. First is the question of how do we think about increased consolidation that occurs after PE investment? And so currently it's important to note that 90% of PE deals are not reported to antitrust regulators at the FTC and the DOJ. And that is because these deals are individually small, but collectively they may exceed reporting thresholds. So after our paper was published, the FTC did decide to make such serial mergers and acquisitions reviewable. The second thing is a very practical concern that funding and more research are definitely needed for antitrust regulators. When you look at the number of full-time positions at these agencies, they have not increased significantly in the past 20 years, whereas, of course, PE deals have tripled. California has considered empowering the state attorney general to review and veto mergers and acquisitions, and we heard earlier about efforts in Oregon that are along the same lines. And this is a very sort of forward-thinking approach because it would empower one individual to think nimbly and to respond to deals and acquisitions. However, of course, it is subject to misuse by one individual should that occur. And of course, these state departments are often overburdened with the number of acquisitions they need to review. Lastly, I just want to say that the issue of staffing is quite important to look at because that is the strongest association with worse outcomes, including higher mortality. In Europe, the European Union has banned decreases in staff for 2 years after PE acquisition, but again, there's very little data to evaluate whether this has been effective. And California, of course, has state minimum hospital RN ratios, which has been associated with lower mortality. Finally, for the question of whether or not we should be regulating leveraged buyouts and asset stripping more tightly, the European Union has established strict limits on leverage, and congressional legislation by Senator Elizabeth Warren would prioritize employees and patients in bankruptcy proceedings should that occur. So I want to thank you all for your attention. I'm always open to talking more, and I really appreciate your time.
Hi, everybody. Let's see if we can see the slides moving. Perfect. Excellent. Hi, everyone. I'm Amy Waldron. I am on the global leadership team for our healthcare industries practice. I focus on the strategy for healthcare and life sciences for North America. And what I'd like to do is I'd like to share with you a little bit about what Google's doing, because there's some channels that are fairly unique that healthcare has been leveraging to kind of change the kind of information that's getting out to the public. Walk you through kind of what we're doing, walking you through kind of what cloud technology has done over the last couple of years, because I do firmly believe that a lot of the investment that has taken place over the last couple of years finally will start paying off with regards to operational efficiency and the consumer experience and health equity. And we'll start seeing this. So I do have a little more optimistic approach. Because of this technology, we're able to get a lot of social determinant and other information gathered and to the right people at the right time. So walk you through kind of what we're seeing, and then if you guys can all stay alert, we've got a video at the end. So hopefully a little bit different. But so people think big tech and their investment in healthcare. I would have to say that the big tech companies are all very different. And in order to really understand kind of how they play and what they're doing in the industry, you have to understand kind of why they were founded. So when you look at Google, Google's mission originally was how do we organize the world's information, make it accessible and usable. So think about like we were founded on search in theory. And so what we've done over time is we've thought about how do we leverage that with AI and ML and the cloud technology. But before we get there, a couple of years ago, we were kind of collectively thinking about what does Google, like how do we impact healthcare? And we impact healthcare through our channels actually quite dramatically. 3 out of 4 people go to the internet first when they have a healthcare question. We have hundreds of millions of searches a day on healthcare questions. There are 12 billion different views that have taken place on healthcare information on YouTube. And then when you switch over and you look at devices, there's 132 million Fitbits out there. And people have actually are tracking their sleep. And there's like 22 million different people who are tracking their sleep through Fitbits. And then last but not least, you have the Android world, where we have almost 3 billion Android devices out there with a bunch of healthcare apps. And then we're going to talk about my area, which is cloud. But when you look at the impact of all of these, whether we like it or not, like we're in the healthcare business because of the information that people seek from the channels that we've created, and over time, how society has shifted towards these different channels. So what we've done is, about 4 years ago, we ended up hiring Dr. Karen DeSalvo, who is our Chief Health Officer. She's our health officer for Google. She also, from a business perspective, has created a team of clinicians, public policy people, as well as public health experts, and have brought them to Google. And we think about those resources. Those resources are actually embedded across all of our products. and they help us have a lens on how are we impacting health. Think about a bias, think about, should something could something be created and put into a product in order to be, higher quality, et cetera. So we actually have a pretty deep bench. And our goal as a company is to help billions of people live healthier lives, which, sounds unrealistic, but when you think about the different channels and how we actually interact with a lot of corporations with regards to cloud technology, it's actually something that's pretty feasible. And what you'll see as we kind of go through other slides of what's being done over the next couple of, I would say, years, like in the next year or two, we're going to start seeing that as consumers. So we all come together and we focus on, there's probably, 40 or 50 different investments going on around healthcare across Alphabet. That's the holding company for Google. And the way that we actually focus on how we come together is we focus on different stakeholders. So we call them our 3 Cs, the consumer, the caregivers, and community. And from a consumer standpoint, what we're thinking about is how do we actually give people access to information and tools when and where they need them. And so examples of this would be, we notice the inequities of people who are trying to access caregivers when they have Medicaid. And so, we took an initiative at Google and said, okay, how can we, when people are searching who are on Medicaid, how can we show them who actually provides Medicaid services near where they live? And then better yet, how can we, what else might that person need? And so we thought, okay, most likely that person, they may need transportation. They might also be food insecure, housing insecure. What else can we actually surface in order to add more value to that person and help them on their health journey? So that's one example. Another example would be our knowledge shelves. So obviously, during COVID and other areas, disinformation is flying everywhere. And so we definitely are not in the business, nor will we ever be in the business of, being that physician, but we do feel like we have a responsibility to actually surface information that's factual. So if you guys search on YouTube or you search on Google search, you'll notice for things like COVID, there will be what we call to be a medical knowledge shelf that pops up. And we've developed relationships with organizations that are fact-based and have well-known brands for certain topics such as COVID, eating disorders, anxiety, PTSD, areas where we're trying to make sure how do we actually surface information to help educate people. And in some cases with YouTube, bring those communities together to help some of the topics that people won't necessarily talk about just from the implications in society. How can we actually serve a purpose in those areas? And now what we're seeing is that corporations are starting to use YouTube and search to also help influence. And what I mean by that is I'm working with an organization right now who is working with a population that has high diabetes. It's an ethnic population, and they're trying to figure out how can we actually help encourage this population to eat healthier. And so what they've done is they've invested in chefs that are popular with that group and said, okay, can you incorporate healthier ways of eating and make this fun and entertaining? And somehow can we engage people where they can actually put pictures up of what their recipes look like after they tried it at home? And some really interesting creative things to make it entertaining for people to improve their health. From a caregiver side, I'll talk about that in a minute with regards to cloud. And then from a community context, this is where, a great example would be COVID. So we're all of Alphabet can come together. And when COVID came out, the first thing that our DeepMind group does a lot of AI and ML and large language model researching. The first thing they did was they're we think we can crack what the protein is for COVID. So they were the ones who discovered the protein, but then they also put it out into the entire research community and said, okay, anyone needs high-performing compute as we're trying to solve this problem, let us know. And so while they're doing that, we're working with our cloud technology group and the pharmaceutical industry on helping with the manufacturing. Meanwhile, while the search team is trying to figure out how can we work with the hospitals and the local governments on where these distribution sites are going to be so we can help people. So that's an example of how this organization comes together and addresses health. What has an implication as well is this middle one, the caregivers, and this is where cloud technology comes into play. And so with cloud technology, think about, like, people are always concerned about Google and information. And I'm a consumer too. So I'm concerned until you actually kind of understand cloud technology. Think about, it's like a safety deposit box in a bank. What is in that box is yours. And so when you look at healthcare and you look at the volume of information that exists, there's 30% of the information that is created in the world is healthcare data. And that is not going to decrease. And I say that because the majority of that data historically has been images. DICOM images are, there's a tremendous amount of storage required. When you look at what we're doing with regards to genomics, and you look at all the wearables, as well as hospital in the home, that volume of data is going to continue to increase. And so data is wonderful, but it's also made the system tremendously complex. Also, when you look at our healthcare system, that data is fragmented. And what I mean by fragmented is that within large organizations, even the same hospital system, you have information sitting in different silos. You also have information that's sitting in different formats. And so we have this great technology over here, like cloud compute, and you've got all these AI and ML capabilities, but how does it actually work in healthcare? And so that's where the technology, I would say it's taken probably 5 years to get where we are today, but 5 years ago, almost 92% of technology for healthcare was still on-premise, which means you don't have that high compute power. So what you saw at that time is you'd see some pharmaceutical industries using it, you'd also use some academic medical centers, but it definitely was not as prevalent as it is today. So the industry had to get to a point where healthcare actually felt comfortable using cloud technology, and then also had the knowledge and ability to understand how to apply it. And so what's happened over time is the healthcare, the cloud basically has been able to kind of prove to the industry that it is a secure and regulated compliant capability. And so first there was this just, is our information safe here? And so the industry understanding how the cloud works and how the different types of capabilities it has to support HIPAA compliance. But then there was the different information formats. So what's happened over time is healthcare APIs have been created that actually have capabilities to ingest information in different formats and bring them together. So that's a start. And then there was, how can we actually track the governance of this data? And so that was great, but then you also have these wearables coming in, and it was, how can we actually provide then consent management controls for all this information coming in? So we finally are at a point where we have these tools that enable organizations to protect the data. They can de-identify it if they need to. They can manage the governance. They can change consent management based on the end user. So we finally have capabilities where healthcare actually can go in there across the entire spectrum and be able to take advantage of the power of AI and ML. And the reason why this is important is because the big loser in this game for a long time has been the consumer. So when you think about all the personalized things that you're able to experience in other industries, people are always like, well, how come we can't do this in healthcare? Well, we couldn't do it in healthcare because we didn't have the ability to take advantage of this technology until all of these things were built in the cloud and all of these capabilities went into play. So, they're there, and there were, I would say, front runners probably about 5 years ago. I think Mayo and a couple of organizations were kind of the first to say, like, okay, like we're going to do this. It's really hard to get a board to say, okay. It was a pretty big deal 5 years ago. And it really was academic medical centers taking that leap because they saw the value of a couple of things. The high performance compute, especially when you look at, like right now, we can diagnose cancer a lot faster than we ever could. That's because of machine learning. And so, we are seeing that become more common practice, which is amazing, and it benefits us all. We just don't necessarily see that unless we have that problem. And so what's happening today, which is, to me pretty exciting, is that now we have all this data that is coming together and being collected, and it can be secured and it can be de-identified. So what you have is you have organizations across the value chain that have the ability to securely share information. And when you think about this, you have a few organizations, more than a few, but like actually probably the large payers and the largest health provider systems, they have had the ability to put this technology in, and they're sitting on massive amounts of data. And over, I would say, the last 2 years, we've started to see big organizations be able to create longitudinal patient records. And that's important. And to think that that was a really hard thing to do. The VA was probably one of the only institutions that were able to kind of capture a customer. And so when you think about all the flexibility that we have today, you can go to CVS to get health care, you can go to Walgreens. There's so many different places you can go. The question is, who really has all that information in one spot so that you can take advantage of predictive analytics? And so where that ends up being in many cases, the payers, the health plans, are sitting on this data because of claims information as well as the connectivity that they have to some of the EMRs. And so what we're seeing is finally people understand that we have so much information right now, and we have the ability to do these predictive analytics, that we can actually be proactive and help people better on their health journey. And so what I'm actually seeing today, and you'll see some announcements coming very soon, is that a few systems have actually created that perfect loop of information from the healthcare provider to the payer and back. And the types of programs that they're running out are pretty amazing when you think about health inequities and being proactive. Is, think about diabetes. Like, they're able to look at the data that they have and say, okay, these populations, like these individual people, like this goes to an N of 1, which is what makes this amazing. But you can actually understand who is predisposed to diabetes based on the information that you have on them. There are a lot of programs that exist that are funded that are not connected to that end user because a clinician doesn't know that they're available. So what we're going to start seeing, and Emory did this a couple years ago where they sent the automatic flag when they thought someone was close to having sepsis, which was a huge breakthrough. And now the same thing is happening with people walking into the ER who they think have a high chance of an opiate overdose. Those triggers are going off in EHRs, in the emergency room. And now we're also looking at these investments where proactively the payers are going to be setting flags for smoking cessation, for digital diabetes programs, and a whole bunch of others. So this stuff is just starting to actually go into production. It takes a long time, and the technology's been there for a while, but the adoption of healthcare has taken a while. And then better yet, like, that investment takes some time. So I am highly optimistic because I really do see that, as I'm working with payers, and I work with providers in life sciences too, I'm definitely not pro-payer, but it's actually good business for them if they can identify programs to help people not go into the ER. And so what we're starting to see is there's a tremendous amount of SDOH dashboards that we're creating with people. And they're thinking about, okay, this population here, quite frankly, if we can invest in housing and food and transportation and early childhood daycare, we actually could change this. So you're also seeing public and private partnerships emerge as well. So at the end of the day, I'm going to wrap it up now. I am optimistic because the data is starting to flow, and I promise you we'll start to see it in the next 12 months. So I'm just going to show you a video quickly. I'm going to skip my GenAI slide and go to a video. So GenAI obviously just popped up overnight for all of us. And so we're doing a project right now with Mayo. It's public. If you want to take pictures of the slide, go ahead. These are all the things that generative AI is good at: searching, summary, and creating content. I'm not going to talk about the clinical side. If you want to ask questions, I'll address them then or later. But the really cool thing is that Mayo Clinic announced this with us. I'm going to show you a video of this girl, Ashley. And so Mayo Clinic is thinking about, we are known for our concierge service that we provide our customers. So how can we actually become the concierge for people in their healthcare journey? And what they've designed with us is kind of like their future vision of tying together public and private information that is like your own personal portal. So this is going to be Ashley. She went on vacation and hurt her foot. She went to her primary care provider, and they gave her a referral, and she's trying to think about what she does next. So let's see if this video works. Okay. company. This stuff is being used by some people now. I'm going to stop it there. The other part of it, yeah. So again, this is the future vision. We're actually working on this now, but I would not be surprised if you didn't see some of these different types of capabilities coming soon, and that experience coming a year from now, given how fast things are moving. So thank you. Hopefully some optimism out there.
All right, that was a lot of presentations, but really amazing and very disparate topics. But I promise you, the Venn diagrams of where we overlap are going to be apparent in a minute. Why don't we just do a few questions to each? I'll pose a question to each of the panelists, and then please get your questions ready. I guess I'll start with Steve, since you kicked off with drug pricing. I wanted to echo, the value framework that Steve's organization has really pioneered is something that we were talking about 8 years ago as, if Congress isn't going to do anything about drug pricing, look at ICER, because you will now hear on earnings calls for Novartis, Pfizer, Amgen, you name it, say they're launching a new drug. Oh, by the way, the price range is going to be within ICER's recommended range. You never heard that 10 years ago, 8 years ago. Now you're really hearing that in a very public and visible way. So I commend you for that.
It happens about once in 100 times, but that's usually they're saying why it won't be within our price range. But thank you. It is something we've aimed for.
So you were talking about those value frameworks and kind of options for paying over time, stop loss, embark, was an example of one. How do you think about, with the gene therapy that might be one and done, $3 million, that patient gets their injection and then off they go, since insurance is generally
priced for 1 year, right? Actuaries price out premiums and deductibles and so forth for 1 year, then the person could leave the next year and move on to another insurer. So how do you do that over time with some of these pricey therapies?
I honestly think we need a Google Assistant for that. And I actually feel like I want to get a stress fracture now. I don't know what, that was extremely good marketing because I wanted to have a stress fracture. I would feel so cared for. Although if there's a patient form out there for people with stress fractures, we have problems. All right. Unfortunately, there's no easy solution, as I pointed out. So people are still trying to figure out this problem where people can go to different insurance companies. How do you pass on, even if you've been lucky enough to frame the payment as a outcomes based over time? What if the member moves to a different health plan? Who then gets the money back, and how do you track that person in space and time? So there's a thriving subculture of companies trying to figure out how to do that crosswalk across health insurers and to try to float some kind of insurance, some kind of almost loan approach for either the drug company or the health plan to be the bridge. But we're in early days. And the Embarks of the world are not solving the problem, partly because actuarially they're still in early days too. And just to be slightly risk averse, they've priced their products such that a lot of health plans look at it and say, yeah, smaller health plans, I think I'll just take my own risk. Because for me to try to carve out that much per member per month and give it to somebody else doesn't seem like a good deal yet. So that's why we're still in early days. And CMMI is launching a new model for Medicaid to try to pool negotiation and outcomes-based contracting. We haven't even seen that launch yet, so there's a lot to be learned, but the business is still a bit of innovation hitting a brick wall in ways that may not be good for patients. So I do think we need rapid innovation on the model for how to pay for these things.
Fair. The outcomes-based arrangement that you mentioned is a CMMI pilot program that's going to be rolling out over the next couple of years, and primarily because of sickle cell, which, as we know, is highly prevalent in the African American population. Medicaid, and quite honestly, we were talking about Liz Fowler before, having been a speaker here. She now runs, she helped draft the Affordable Care Act. Now she runs the Innovation Center, and they have now come out and said, look, the reason why we're doing these OBAs is because of sickle cell potentially making Medicaid programs, state Medicaid programs, bankrupt. So. And that creates, I guess, an equity angle. So Rishi, I want to bring you in here, kind of your thoughts and perspectives on anything that Steve mentioned around social determinants, equity, and kind of these types of new therapies. But also, I want to also pivot to some of the kind of food and things you were talking about in your remarks.
What I appreciate about this panel, including just to maybe build on, Steve, what you're talking about, is that there's a similar problem right now, and I think therefore an opportunity when it comes to innovation in the payment models, rather than innovative new X, Y, and Z kind of therapies. And that's relevant in the equity space, for example. There's a lot of folks who have the free rider problem right now with, should I invest in as a plan or as a hospital system in this food pharmacy or this medically tailored meal kind of intervention or a solution that is clearly going to lead to better outcomes, but not necessarily accrue just to me? What about the other hospital putting some skin in the game if they're going to benefit from my patient who's going to go to their clinic, et cetera? And so I do think that there's it's still early days and there's a lot of innovation, though it's still happening around how to, the models of how to bring together different folks who have vested interest in a similar set of outcomes in a given geography. So trusted broker models, for example, are one model that's been tried to be able to bring together with a trusted broker these different stakeholders in one community and start to say, well, what's the value that you would pay for a 15% drop in or 15% reduction in inequities for this condition or that condition? And everybody goes around and assigns a value, and the broker then says, here's therefore what the value is. Can we now collectively purchase this from the vendor or from the provider, and then make sure that everybody pays equally but also gets the benefit they want? This is still really early. We haven't really done this in the US at all, but the point of changing business models, the point of this panel, and to identifying bright spots or innovation, I think there's a lot of energy, talent, and real opportunity when it comes to innovating the different payment models, the ways to kind of convene funds rather than just finding the point solution that's going to solve it all. And that's especially true, I think, for equity and social determinants.
One more question. Mina was talking this morning from CMS about supplemental benefits, this idea that, the Medicare Advantage plans are able to, provide Ubers and Lyfts, right, like fresh food, silver sneakers, dental, vision, hearing, the list goes on. A lot of seniors aren't using them, but some of them are, and now there's a little bit more of a focus on like, okay, what are these benefits? Are they really truly health enhancing? And you were talking about similar benefits on the Medicaid side, so I just want to hear you bridge the gap on that for a minute.
Yeah, as healthcare gets more involved in thinking about now investing in or paying some sort of, paying towards food, housing, and transportation, some integration of social services, interventions to advance equity, there's a lot of unknowns when it comes to what's the evidence base showing me in terms of outcomes. There are libraries. UCSF hosts a library by an organization called Siren, a wonderful organization that is, from the health services research perspective, bringing a lot of the best research when it comes to health and social service integration. And I think that while that's a tremendous kind of benefit to the field, particularly research, we still need, I think, the ability to pull together the library of investment and that could be available to healthcare to really say, okay, well, here's what the outcomes are clinically, health-wise, and also here's some of the value propositions. The more we can do that, the more for Medicaid, Medicare Advantage, or Medicare traditional, we can make sure that people are making wise, informed decisions rather than kind of throwing spaghetti on the wall and hoping that social determinants will get better.
Chris, I loved your slide deck. Can I borrow some of your slides, actually?
Yeah, thank you.
So I guess, you talked about a lot of wonderful data points and trends as you kind of step back and think about the body of research you've done and then some of the studies that you presented. Where do you think private equity has a role? Where maybe it doesn't have a role? And again, specific to healthcare.
Yeah, I think that's a really good question. I think that the most important thing is ensuring that patients are not harmed after any change in ownership, whether that is for-profit, private equity, public ownership. And so to me, the most concerning evidence is from the staffing reductions, and that is really closely tied to the increases in mortality. I think that there are certainly avenues for private investment in our healthcare system, and it's the job of policymakers to ensure that those avenues are appropriate and that people, if you do make a business or a healthcare entity better, you do deserve to have a reasonable profit. But if you purchase an organization and you sell the real estate and you decrease the staff, and those are the only changes you make, and patients suffer because of that, I think as a society, we have to ask ourselves, is that something someone should profit from? If you add value in different ways, maybe the answer is different. But I think moving forward, the most promising legislation has to look at whether or not we want to limit debt, whether we want to enforce staffing minimums, and whether or not we want to automate review or denial if mergers exceed certain quantitative thresholds for market concentration. And so I think those are certainly on the mind of regulators at the FTC and CMS, and certainly on the minds of congressional leaders as well.
We probably have time for one or two quick audience questions, but FTC, as you probably know, is looking into private equity and doing a full day session on this, I think, in a couple of weeks. Go ahead.
Wonderful panel, Ipsita, beautifully done last year, this year again, and thank you. Amy, my question is for you. It was a great talk. The last part was the best. The way you helped patients and families to negotiate healthcare encounters, healthcare costs, amazing and true. So we have to have some technology solutions to the various problems that we're discussing this whole day. Thank you for being there for us. My question is, if the same stress fracture that Steve wants to have, hopefully not the one I'm describing, required in-hospital care, fixing by screws, couple of nights stay in the hospital, to our experiences, those costs are much more opaque. Have you negotiated the inpatient hospital cost barriers for disclosures? And if you have, God bless you. Because by mandate, they're required to post those charges. But the difficulty I'm defending the hospital here, there's so many vendors that it's very difficult to do. And that's a bigger cost for any patient.
Actually, no. The point solutions, the fragmentation in the healthcare environment is still, it's not an efficient system by any means. One of the challenges to actually delivering an experience like the one I showed you is that you've got to have the quality of data behind the scenes, and you've got to have the connectivity, and you've got to have that flow, which we don't have yet. We have bits and pieces of that. And when you start also thinking about like the clinical components of a diagnosis and then what the care is going to be, like there are a lot of things that have to come together. But the health plans and some of the major providers are trying to figure out how we can do this, and it's for many reasons. They need the consumer to be much more engaged in their health. And so they're trying to figure out not how they do like point solutions, but they're trying to think about how do we create programs, how do we support people's health. So that experience is an example of how can we actually like be the app that someone like embeds in their life. When it comes to the specifics about how much a more complicated procedure is going to cost, I think we've got a way to go on that. Google is not doing that. Google is actually, technology is a tool. And so what people don't necessarily have a good grasp about is you've got to make sure your quality of data behind the scenes is good. And it certainly isn't one that should be making clinical decisions. It's one, it's something that's meant to be like an aid, and like I said, it's a tool. So I think you'll see components of that come together, but when you're talking about more complicated situations, then that's not easily thrown into an app like that.